Hello, my name's Samantha Mann. I'm a consultant ophthalmologist at St Thomas's Hospital, and I'm also the clinical lead of the South East London Diabetic Eye Screening Programme. I'm going to be talking to you a little bit about the Diabetic Eye Screening Programme and how it fits with ophthalmology and our new OCT screening service. So you don't need me to tell you that diabetes is on the increase. The International Diabetes Federation has now estimated that by 2030, we'll have almost 43 million people with diabetes. That's mainly adults. And we know this rise is due to increased life expectancy, sedentary lifestyles, and also increasing levels of obesity. Diabetes is still a significant cause of blindness, although it's no longer the top cause, which is now due to hereditary retinal disorders in working age adults. It's the second most common cause. And we know that up to 30% of type 2 patients and 56% of type 1 patients will have some level of retinopathy. And between 3 and 11% of this will be sight-threatening. The aim of the screening programme, and we invite patients once a year for their eyes to be screened, is to reduce the risk of sight loss. And we can do this by prompt identification of eye disease and allow the effective treatment at an appropriate stage to prevent this blinding disorder. So we divided into what we call diabetic retinopathy and diabetic maculopathy. Now, the retinopathy is progressive, it goes from stage 0, R0, all the way through to R3. And it can be quite a slow process, but it does depend on when you are actually diagnosed. Some patients are diagnosed late, so they may have more extensive levels of retinopathy. Unfortunately, only get symptoms in the late stages, and this is actually much more difficult to treat. The early stages, so the R0, the R1, and the R2, can only really be detected by a photographic screen, as we do in the diabetic eye screening service, or an eye check with your eye physician, eye optometrist, or ophthalmologist. And the late stages are the ones that cause the visual loss. So if you look at these pictures below, you start with R0 grade, move to R1 with a few microaneurysms, and then move to an R2 if you start developing other changes, like more hemorrhaging at the back of the eye and what we call ERMAs, or intraretinal microvascular abnormalities. So these are all asymptomatic, and you can get quite extensive R3 changes with abnormal blood vessels growing on the back of the eye, and all of this is asymptomatic, and you wouldn't have any symptoms. And at this stage, you would need an urgent referral for laser treatment. If you left it and wasn't referred, you could end up with bleeding inside the eye and the gel of the eye, and this would cause blurring of vision and can lead to sight loss through vitreous hemorrhage and retinal detachment. Ordinarily, a diabetic eye screening program would refer anyone from R2 onwards to the hospital eye service for further monitoring and treatment as required. So what about maculopathy? Well, we also grade each eye for maculopathy, and all of these 3 photographs here are an example of what we call M1 maculopathy, and this is a referable grade. We would traditionally refer all of these to the hospital eye service. Now, these can range from completely being asymptomatic, the first picture here where you just have a single exudate, and this can quite happily be monitored for some time before they need any treatment. If they start to get more of a cluster of exudates towards the back of the eye, then it may be that they require a small amount of laser treatment. And if they have more extensive exudates at the back of the eye, they may actually need some injection treatments, which would be carried out in HES. So traditionally, we refer all of these, but we know that at about 90% of these patients don't actually need treatment at this stage. They have early disease, which is sometimes reversible with good diabetic control, only when they get to significant level of pathology that they would need treatment, and hence referral to the hospital eye service. We know that there is an ethnic importance here. Those with from Afro-Caribbean origins will have 3 times more likely to have maculopathy requiring laser, and twice as likely to have sight-threatening retinopathy. And we do have a very high proportion of Afro-Caribbean in our South East London population, hence needing to monitor them more closely for maculopathy. We have developed this OCT clinic now within DESP, within our diabetic eye screening program, to allow many of these M1s to stay in the screening program, where images are taken within screening on an OCT machine, which are machines especially able to monitor maculopathy more closely than just colour photographs. And these images are viewed by our DESP practitioners, and then they can either stay in the OCT clinic, or they can be referred if the disease carries on. More extensive levels can be referred appropriately to the hospitalised service. But we managed to keep up to sort of 80 to 90% of our patients within the OCT service. A few years ago, we had a diabetic specialist nurse sitting in with our OCT clinic and looked at diabetic control and blood pressure control of these patients, and was able to communicate with the GP regarding the medication changes, and that deemed to be very useful for the patients, because at this stage the disease was relatively reversible, and so was able to maintain and slow down the progression of the maculopathy by intervening at this stage. This is an example of an OCT scan which you can use to monitor the maculopathy, and it shows the thickening and swelling at the back of the eye in more detail. And this example would be a typical example that should be referred to a hospitalised service to allow some laser treatment. So within DESP now, we have highly trained graders. We actually have 2 OCT surveillance practitioners who have been trained in the course in Gloucestershire, but we're now developing our own in-house OCT training resource with a certificate, and that's very much with KHP. Together with KHP, we've been able to develop this e-learning module, which is still in its final stages, but we've been able to produce 8 modules with different stages, and all explaining about how the different stages of retinopathy can be detected on OCT scanning, and also other pathologies that can be detected. We currently have OCT clinics very much part of our desk service. We have several locations, 6 different locations now, and we see about 700 to 800 patients a month. We have 2 specially trained OCT desk practitioners to interpret the images, and we're able to see all of our M1s in-house without having to refer all of them to the hospitalised service. And then only those that develop a certain level of maculopathy would then be referred onwards. And we can see patients 4 to 6 monthly instead of yearly. But unfortunately, we are reaching saturation point within the service. So we do need to think about expanding into ophthalmology and using some of our trained practitioners to help the ophthalmology services with the low-risk monitoring using OCT scanning and wide field imaging. And this will ultimately allow more capacity in the MR clinics to be able to see and treat those that need laser and injections, rather than monitoring the lower risk patients, which could quite happily sit in the desk service as part of the surveillance programme in order to be reviewed. I hope that's explained a bit more about what we can offer in DESP and part of our surveillance pathway, and we hope to expand this to a much larger role in the future. Thank you.